Good evening,
Proceed.
good afternoon, Dr. Siddiqui. Good afternoon, Govind. A very warm and hearty welcome to this very interesting subject that we have chosen today on acute undifferentiated fever. Now, we live in a country today where we're surrounded by fevers. In fact, it is at the height of the fever season at present. And given the physiological differences, the symptoms, sometimes diagnosing the correct fever between a dengue, a malaria, a chikungunya, or a leptospirosis can be quite a challenging task. So getting the diagnosis right, getting it accurate is, I believe, the prime importance of most of India's diagnosticians today. And we are very happy to have with us Dr. Areena Hoda Siddiqui, Head of Department of Microbiology at IIM SR in Lucknow. Welcome on board, ma'am, and over to you. Just say next whenever you want the slide to be changed, and my colleague will facilitate that from his end. Over to you, ma'am.
Okay. So first, I would like to thank JMitra for organizing this CME and also on this topic, which is the need of the hour. And also we know that this season of fever is going on, and we are getting a lot of cases of fevers who are admitted in the hospitals, and the hospitals are full with patients. So I would like to start with the saying, humanity has enemies: fever, famine, and war. Of these, by far the greatest, by far the most terrible is fever. So these were the lines which were said by William Osler long back, and that still holds true. So today's topic is acute undifferentiated fever. And next slide. I would begin with a definition what acute undifferentiated fever is. So initially the terminology what we were using was fever of unknown origin or pyrexia of unknown origin. But now the acute undifferentiated fever has also come into picture, and where they have defined when we have to say acute and when we have to say it as pyrexia or fever of unknown origin. So there will be a brief introduction followed by the factors affecting this acute and differentiated febrile illness, then proportion of AUF, management, diagnosis and management of the fevers. Next slide. Okay, so introduction may I told that now we have got a new terminology, that is acute undifferentiated fever besides pyrexia of unknown origin or fever of unknown origin. So the definition is almost same, fever in all the three categories, but yes, there will be a difference in the duration. Like when we say the fever is of less than 2 weeks duration and still we are trying to find the etiologies, then we say that it is acute unfebrile illness. But when it is more than 3 weeks, then it goes to the category of FUO. So this is the first and the most important difference into two categories. And fever of less than 2 weeks duration without any organ specific symptoms at the onset is something when we say that it is AUF. And there are very weak symptoms like headache, chills, myalgia, and later on there may be involvement of few specific organs. And also, if these acute febrile illness, they are not taken care immediately, they will lead or they will progress to some really life-threatening illness, which we have to take care immediately. And it is also being reported that the mortality related to these are 12% in severely ill hospitalized patients in tropical regions. So we have to differentiate, we have to start management. So coming to the challenges, what are the challenges? So first and foremost, the duration. Second is the non-specificity of the symptoms and signs. So headache, myalgia, generally we do not understand whether actually it is any specific organism related illness, or it is the just symptoms which will go by own. So this is one of the major drawback of these AUF, and lack of availability of accurate diagnostics. So that is also very important. Then many causative agents like virus, bacteria, protozoa, and rickettsia. So these are associated with AUF, but still the third point, which is very important, is lack of accurate diagnostics in each and every setup lab which is present in our state. So we don't have the amenities, we don't have the proper testing available, and also the resources are very poor, so that the patients coming to the hospital or coming to the doctors, it becomes very difficult, like where to send the sample, which labs are testing these cases, and if at all the lab is providing these tests, then the affordability also becomes an issue. In a resource constrained lab, or in a medical colleges which is catering very poor people, then it becomes very difficult for those people to afford those tests. So affordability is a challenge, and also not every lab has all those diagnostic amenities. So according to 2014 systematic review, the proportion of undiagnosed AUF ranges between 8% to 80%, and 20% of all acute febrile illness have malaria. So we have the major cause malaria as AUF. Then we have 10% have rickettsia and influenza, 5 to 10% they have dengue, enteric fever, leptospirosis, or Japanese encephalitis. So these are the differential diagnoses which one should keep in mind when treating a patient. Next slide, please. Okay, so coming to all the causes. So first and foremost, as it is said that malaria is one of the most common cause for the disease of AUF. So we have to test for malaria. So all malaria, like malaria due to Plasmodium falciparum, P. vivax, ovale, P. malari, and knowlesi. So these are the important causative agents we need to think of. Many a times the testing facilities, they only report falciparum and also the ovale, the vivax, whereas the other species, it becomes very difficult at the laboratory where it is very resource constrained. It becomes very difficult to identify unless until they are performing some kind of molecular methods to find out those species. Then we have arboviral infections, and which is very common these days, like dengue, chikungunya, Japanese encephalitis. So these should be ruled out whenever we are getting a case of fever who is giving history of 3 to 4 days. So these are the tests which should be ordered in the patient so that the right diagnosis and the treatment can be initiated in those patients. So next, most common cause is enteric fever or the typhoid. The causative agent is Salmonella enterica, Seroa typhi, and paratyphi. So this also should be kept in mind. Spirochetal infection like leptospirosis and tick-borne or the louse-borne relapsing fever, these also can cause very important diagnosis. I mean, one of the differential diagnosis in AUF cases. So these also should be kept in mind. And last but not the least, the rickettsial infections, where we have seen ScrubTyphus. Many a times we have seen cases of meningitis, patients with seizure, patient where we do not get any history of any organ except the CNS symptoms. So ScrubTyphus, many a times we get the patient positive for ScrubTyphus. So that is very important to rule out. Then also the other typhus like the murine typhus, the spotted fevers, these are the differential diagnosis which should be kept in mind by the treating consultant so that accordingly the tests can be ordered and also the treatment can be given to the patient to save life of the patient. Next slide. Okay, so coming to the classification of acute febrile illness. So we have a case of fever, and it is case is being suspected as a suspected malaria case. So acute localized infections, we will look for the respiratory, the urinary tract infections, or the GI infections if it is there or not. If not, then it will be classified as acute undifferentiated febrile illness, and the test we will look for the malaria. And also the non-malarial causes which were discussed in the previous slide, the other causes, if suppose the patient is malaria negative and still the patient is having fever, then besides the CBC findings and also the test, LDH, SGOT, SGPT, we also need to test for the other causative agents, the agents which are available in the lab, so that we can come to a final conclusion what the patient is having, what type of disease the patient is having. So in one is malaria, then in non-malaria, what we can suspect of, if we are suspecting of viral, then it can be dengue, chikungunya, Zika virus, Japanese encephalitis. And the influenza is also very common. Having a patient will have some respiratory symptoms, the fever, sore throat, and that goes off, that is generally self-limited. Then under bacterial causes, same, we have enteric fever, and also like E. coli and Staph aureus may sometimes be responsible for AUF. Then the zoonotic infections like spirochetes and leptospirosis, the relapsing fever, rickettsial infection like the ScrubTyphus, murine typhus, spotted fever. So these also can cause AUF. Then parasitic, hepatic amoebiasis, schistosomiasis, trypanosomiasis, these also can be kept in mind depending upon the area from where the patient is coming. Next slide, please. So what are the factors which affect acute undifferentiated fever? First is the disease burden. So we should be knowing the epidemiology, the disease burden of our region. And like we know that there is seasonal variation for this malarial disease. Then dengue also, there are particular seasons. Then also every third year we do have epidemics. So all that should be kept in mind, and accordingly the patient should be treated. Then also the seasonality of infectious disease, which I discussed. Then another, the rainy season is very important for the ScrubTyphus. Then leptospirosis and melioidosis peak during the rainy season too. Then also we should be knowing if the patient is having these symptoms, and what could be the DD, and how, like what could be the severity of the disease, where all the particular parasite or the particular organism can affect, which other organs can be affected. So what severity can be when the patient gets infected. Very important is availability of the diagnostics. Also, the consultant should be made aware that what are the tests which are present, which are available, and which can be ordered by the physician, so that he can come to the conclusion. The physician must know what are the tests which are there in the hospital, in the lab, or in any college, so that accordingly he can order the test. And also the healthcare facilities. So this is very important. The last two is very important, the availability and access to healthcare facilities. So I think with the help of these kind of CMEs, definitely we are going to raise the standard of knowledge and awareness among the physicians and other colleagues, so that they can also know what are the testing facilities are available, and they can just guide the patient for the testing. Next slide. So acute undifferentiated, as I told, acute when it is less than 21 days, and it can be diagnosed or undiagnosed. When undiagnosed, and if it gets resolved within 2 to 3 weeks, and if it is unresolved, then we say that it is FUO. So this I told in the very beginning. Next slide, please. Next slide. Okay, coming to the onset, duration, and pattern of the fever. So malaria and other arboviral infections like ScrubTyphus, leptospirosis, they have an abrupt onset and can rapidly progress to complications in the very first week of infection. So this is we should take care. The moment the patient comes, we should be able to treat them. Otherwise, the disease can become very fatal. And also the diagnostic, every disease has diagnostic features that should be kept in mind. Peak in temperature every other day is seen in malaria due to Vivex and ovale. Fever more than 39 degrees centigrade, that is 102.2 Fahrenheit for more than 3 days with abdominal pain, diarrhea, and constipation can suggest tropic fever. Dengue has a self-limiting course with fever for up to 7 to 12 days. And fever in influenza generally lasts for 3 to 5 days and it is self-limiting. But if many times influenza, if it is not treated properly, if the conservative management is not taken, then the patient is immunocompromised or the patient is not healthy, then he can have some secondary bacterial infections. So that is very important. Then coming to next to the diagnosis. Next slide, please. Diagnosis. Yes. So here, next slide. So here you can see this is a chart where you can see the different tests for the different diseases which are available. For example, for malaria, the gold standard is presence of parasites in blood. So presence of parasites in blood is the gold standard. And the drawback is it needs skilled staff. So skilled staff is important so that they should know what are the RBC and WBC, the eosinophils and the various cells are present at the same time. The he should be able to identify the parasites which are present in the blood, and if the staff is skilled, then nothing like that. If at all there is problem, then the second test is RDT, rapid diagnostic test for malarial antigens. It can detect parasite antigens in the blood and it is 95% sensitive. And disadvantage is it can be positive even if the patient is treated. So many times that can also be happen. Antigen can be present, but these are the two tests which are available. Coming to the next test, that is dengue. For dengue, again, we have the CART test, the rapid diagnostic tests, which are available with us. And also we can have ELISA, which is better than the CART or the rapid diagnostic test. ELISA is better and that can be done. And all the three parameters like NS1, IgM, IgG, these all can be tested for the patient if any consultant or any treating physician is suspecting dengue in the patient. And also we should keep in mind that the NS1 antigen generally becomes positive after day 2, and it can remain positive maybe till 6 days, but the sensitivity decreases. So that should be kept in mind. And the IgM, after that, the IgM starts rising. So if the fever is for more than 7 days, then it's better to go for IgM dengue. And it's always better to go for ELISA than CART testing, as the sensitivity of of the ELISA is better, that is at 3%. Next slide, please. Okay, so coming to the next test, that is the enteric fever. So again, we have the rapid RDT, that is rapid diagnostic test, that is for antibody, which detects antibody against salmonella in single serum samples. The sensitivity is 69 to 78%, and the turnaround around time for this test is 2 to 4 hours. Disadvantages is it depends from kid to kid. No rapid diagnostic test for enteric fever is accurate. So these are the things we should be kept in mind. So culture is always the gold standard, but culture should be sent in the first week of fever. Generally, after second week, the positivity for the culture decreases. And so first week we can always send culture. If second week, then we should go for the antibody detection for this enteric fever. For Vidal test, if there is more than 4-fold rise in titer, then only it is diagnostic. And sensitivity depends on the local affordable prevalence, and the specificity is 100%. And this advantage is like more than 4-fold increase may not occur in partially treated patients, and more than 4-fold rise can be missed if antibody level peaks before first specimen is collected. So these are the things which should be kept in mind when we are testing for the typhoid fever or the enteric fever. Next slide. So coming to the next organism, that is the ScrubTyphus, which is responsible for acute undifferentiated febrile illness. And for ScrubTyphus, again, we have a rapid diagnostic tests available. We also have ELISA, which are available, which now for specific IgM using recombinant antigens, more than 4-fold rise in the titer or seroconversion. So the disadvantages, like it can remain elevated over diagnostic cutoff for 12 months post-infection. So this is also something which we need to keep in mind. IgM ELISA, and one more test which is important, that is microscopic agglutination test for antibody. A 4-fold rise in titer is diagnostic for this test, and it is very expensive and it needs high technical skill. So generally the ScrubTyphus, the rapid diagnostic test, and the ELISA, which is detects IgM, they are generally used, and they can be used for the diagnosis of the patient. Next slide. Next. There are certain tests besides what I discussed, the rapid diagnostic tests which are easily available. Then also we have ELISA, we have Vidal for typhoid detection. Then also nowadays in this era of molecular detection, and also this is era of whole genome sequencing. So there are tests where like there are panels, 5 panels, where they just take the sample of the patient and detect so many antigens just in one go. So we have multiplex PCR, we have many technologies are coming which detects 30 or maybe from 10 to 30 parameters just at one stretch. So that also can be utilized, but only the drawback is the test is very costly. Not all labs are performing these tests. Very few labs have these robust technologies and also the skilled people who are doing it. But yes, these tests, when we compare with ELISA or the rapid diagnostic methodologies, they are always better. Next slide. Next slide. Yeah. Coming to the management. So like we should, when the patient comes in the OPD, what we have to take care, we have to take the history of the patient, we have to examine the patient, we have to see whether the patient is having altered sensorium, the blood pressure of the patient, whether it is less than 90 or not, then whether the respiratory rate, whether it is more than 24. So all these things we have to rule out. Also, the clinical features related to localized or the organ-specific clinical features also should be considered. Like if the patient is having cough or dyspnea, then we should think that he is having some respiratory problem. Headache, seizures, stiff neck stiffness, these are related to CNS problem. Then if the patient is having dysuria, hematuria, urgency, frequency, then yes, it is related to urinary system. Then abdominal pain, diarrhea related to GIT, then abscess for ankles. So these all should be taken care when the patient is coming with a history of fever. Then Also, we have to evaluate for SIRS. We also need to find out whether the patient is in sepsis or not. So for the sepsis, it's generally the patients who are admitted to the emergency, and also like there in the emergency there are like SOFA scoring or the Q SOFA, which is generally used to find out whether the patient is sepsis or not. And once we just have seen all this, we have taken care of, we also need to find out where there is any exanthematous fever or exanthem type. So all these we need to rule out when the patient is coming with a history of fever. Also, if suppose any organ specific symptoms is there, suppose patient is having the symptoms of UTI and also the patient is having fever, then accordingly we need to manage. If the patient is having the meningitis, and then we need to manage as per the organs which are involved. But if suppose we are not able to find these, then we have to look for other sign and symptoms like fever with jaundice. Algorithm is fever with jaundice algorithm. So we can just think of malaria or some kind of hepatitis or leptospirosis or drug-induced hepatitis or hemolysis. So this is how we have to go about when we see a patient who is having fever. So these should be considered. Next slide, please. Okay. So, like the patient has come to the department, we have taken the history, we have seen whether the patient any organ specific sign and symptoms, we have ruled out sepsis, all that. And then now comes the stage of investigation. Like what are the investigations which we need to give for those patients who are coming? And first and foremost, CBC. CBC is mandatory and like it is the basic test which we should order in every case of fever. And CBC has so many parameters, and with just the CBC parameters we can just find out, like for dengue, platelet is very important. For any infection, the TLC rises. We have seen the eosinophil count going to 0 when the patient is in infection, and many a times with the start of right antibiotic, the eosinophil count rises from 0 to 1 or 2. So these are the parameters which are very important, which shows the patient is having any infection or not. And if suppose with the history we are suspecting the patient for malaria, then yes, HRP2 or PVLDH. So these are the tests which can be ordered for the patient. And if the patient is negative for malaria, then we should investigate for dengue. Then if the patient is positive for dengue, then dengue evaluation algorithm, then warning signs are present or not, whether the patient is in septic shocks or severe dengue. So all that should be considered. If again the patient is negative for dengue and still the patient is having fever, then we have to continue with the antipyretic, and also the other diagnosis, the differential diagnosis should be considered. Next slide, please. Okay. So if the patient is negative for malaria, for dengue, and the fever duration is more than 3 days, then reassess the severity, altered sensorium, the BP, the respiratory rate, then again reassess for any localized features like whether the respiratory CNS or other organ systems have been involved or not. So again, we have to reassess. And also the differential diagnosis. What are the other differential diagnosis? The enteric fever, leptospirosis, ScrubTyphus, any other arboviral disease, paramyxoenteroviral infections. Then we have to obtain the also blood culture. This blood culture is very important. Suppose if the patient is having fever and it goes in 3 to 5 days, then it's okay. But otherwise, in the case of typhoid fever, blood culture is very important. And if we give, if we send blood cultures after initiating the antibiotics, then for the lab it becomes very difficult to tell what kind of organism, what kind of bacteria was there. And also here I would like to recommend that single blood culture bottle is does not yield like the percentage for yield is 66% if only one blood culture bottle is sent to the lab. So what we suggest as a microbiologist, as a lab personnel, it is always said that one set of blood culture means two blood culture bottles with 8 to 10 ml of blood. That is very important. When we send, then only the sensitivity increases from 66% to 80%. So if we are sending one bottle, then definitely we are not finding. And if we are sending the starting or after initiating antibiotics, then again we do not get any organisms. Then besides blood culture, it is also important to send urine culture and also the chest X-ray for any respiratory infection. So this is how we have to go for a case of fever. Next slide, please. So initiate empirical antibiotic therapy while waiting for the results. So while we are diagnosing, while we are investigating, while we are doing our work, we should always initiate empirical antibiotic therapy. And we should also at the same time wait for the result so that whatever result is, we can change the antibiotics according to that disease. So what are the differential diagnoses? The enteric fever, the leptospirosis, ScrubTyphus, arbovirus, enteroviral infections. So again, this is again and again the same differential diagnosis, the same organisms which are responsible for causing AUFI. Again, we have to reassess the severity criteria and like we have to go for the blood culture. So that is also very important. Urine culture, just chest X-ray, and search for alternate localized etiologies. Abdominal imaging, repeat chest X-ray, consider some CNS infections. If suppose many times ScrubTyphus presents with the meningitis and seizures, but suppose if it is negative, then really we need to look the other causes and other CNS infections which are responsible for these features. Next slide. Okay. So what are the red flag signs? So red flag signs, they are prostration. The patient is unable to stand, sit or walk without support. Temperature more than 45.5 degrees centigrade or less than 36 degrees centigrade. Respiratory rate more than 22 breaths per minute, or oxygen saturation less than 92% on room air. The circulation blood pressure is less than 100 mm of systolic, cold clammy limbs. So these are the red flag signs which we need to investigate. Next slide, please. So coming to the other red flag signs, like if the patient is having some neurological deficits, some altered mental status. So Glasgow Coma Score is very important, which should be done on each and every patients who are admitted in ICU. And if it is less than 13, then it is red flag sign. The convulsions, the positive meningeal signs such as neck stiffness or cardiac signs, abdominal pain that is severe or persistent, vomiting, bleeding from nose, gums, or venipuncture sites, hematosis, melena, jaundice, on examination of sclera. So these are the red flag signs we have to take care of. Coming to the next slide, please. Treatment. So we have seen the presentation. We have finished with the sign and symptoms. We have finished with the investigations which we need to do, and also coming to the treatment of common fevers. Next slide. Starting with the malaria. Next slide. So we are having a suspected malaria case. Slide is positive for P. falciparum or any of the malarial parasite, then what we have to start? We have to start artemether or lumefantrine or primaquine. And if it is positive for P. vivax, then chloroquine for 3 days or primaquine for 14 days, 0.25 milligram per kg body weight daily. And if it is negative, then we need not to give the, and we have to treat as per clinical diagnosis. Next slide, please. Okay. So treatment of uncomplicated. So where microscopy result is not available within 24 hours and clinical suspected malaria case, then we have to perform rapid diagnostic test. If it is positive for P. falciparum, if it is positive, then again we have to treat the patient as per the guideline, and if it is negative, then again we need not to treat the patient, and we have to treat the patient as per other clinical diagnosis. So here I would also like to emphasize that if the tests are negative, then definitely we need not to start, or we need not to give the anti-malarials. Only if the tests are positive, then only we need to give the patient or we need to keep the patients on anti-malarial drugs. Otherwise, it is not recommended. Next slide. Okay, so what are the WHO guidelines for the treatment of malaria? So antipyretics should be given if the temperature or the core temperature is more than 38.5 degrees centigrade. Paracetamol as at a dose of 15 milligram per kg body weight every 4 hours is to be given. And we can give the paracetamol, it is said that we can give 4,000 milligram per day. Like this is the maximum dose which is allowed in the patient. The other drug is ibuprofen, which has been used successfully as an alternative in the treatment of malaria and other childhood fevers, but it is not recommended because of the risk of GI bleed, renal impairment, and the Reese syndrome. Okay. So coming to the next slide, that is dengue. So next is dengue. So coming to the dengue management. So if we have a case of dengue and it is without any warning signs, then bed rest is advisable. During acute phase, antipyretics can be given to lower the temperature. Fluid intake is very important, which should be given to the patient. Oral fluid and electrolyte therapy is recommended for patients with excessive sweating or vomiting. Cold or tepid sponging can also be chosen as alternative if the temperature is high, and this will help to keep the temperature well below 38.5 degrees centigrade. Aspirin like NSAIDs, ibuprofen should be avoided. So this is very important and very important. Aspirin and NSAIDs. So in these days when we are having fever, when this is the season of dengue, when this is season of malaria, so though we know that aspirin and other NSAIDs can be given for the treatment, but yes, we should avoid using these drugs during this time, because we know that the dengue is prevalent, so we should go for paracetamol. Patients should be monitored for 24 to 48 hours after they become afebrile for the development of complications. So many times the patients after becoming afebrile, they develop complications. So that also should be taken care of. Next slide, please. Okay. So management of dengue hemorrhagic fever and dengue shock syndrome. So patients should be hospitalized and monitored for platelets and hematocrit regularly. IV fluid therapy should be given. That is the cornerstone for the management of dengue fever. Crystalloids to be used in fluid resuscitation. Dextrose, normal saline, and rigor lactate can be used for fluid replacement. So if it is grade 1 and 2, then fluid should be started at 6 milliliter ml per kg per hour for the first 2 hours. and the rate can be reduced to 3 for the next 6 to 12 hours and discontinued after 24 hours. And the fluid rates can be increased to 10 for the next 1 hour. So depending upon the first 2 hours, we can either decrease and increase. Then the dengue fever grade 3 and 4, immediate volume replacement is important. And that too now we should use steroids, that is 10 to 20 ml per kg per hour for the first time. Then fluid therapy gradually tapered over next 24 to 40 hours, or colloid replacement at the rate of 10 to 20 ml per kg per hour can be done. So this is how we are going to manage the dengue fever. Next slide, please. So management of dengue hemorrhagic fever and dengue shock syndrome. So the role of platelet transfusion in DHF. So no benefit has been reported or recorded following platelet transfusion.
Ma'am, we're having some, I do believe you're having some technical difficulties. Your audio is not coming clearly.
Okay, so there was a drop. Hello,
It's fine.
am I
Loud and yeah.
audible?
Can't hear you now, right now. Some challenge with the network, I believe.
Am I audible?
Now loud and clear, ma'am.
Okay, so coming to the role of steroids in dengue hemorrhagic fever. So there is no indication. Audible? It is audible? Okay. Okay, so there is no role of steroid in dengue hemorrhagic fever as per the guideline. And criteria for discharge for the patient: absence of fever for 24 hours, return of appetite, and the platelet count is more than 50,000. So this is for dengue shock syndrome. Coming to the next slide, please. Next slide. Okay, next slide. Next slide. So for treatment for OPD cases for the enteric fever, we have cefixime and azithromycin, and for indoor cases, we have ceftriaxone and ofloxacin as the second line. So next slide. Okay, so if an individual is, next slide. Just hold on. So coming to, we have finished with the enteric fever. Now coming to the leptospirosis. So we have the doxycycline or amoxicillin or the ampicillin as the treatment. And in severe cases, we can have penicillin IV or ceftriaxone or cefotaxime. Treatment of ScrubTyphus, again, we have doxycycline and azithromycin. So next slide. Okay, so to conclude, I would like to add upon that acute and febrile illness poses a diagnostic and therapeutic challenge to the clinicians. Every year, different parts of India are affected by different seasonal fevers leading to high morbidity and mortality. Most of them need early empirical treatment, which is on the basis of clinical evaluation during their presentations. The treatment approach should be aimed at achieving a definitive diagnosis as soon as possible. So for definitive diagnosis, definitely we have a lot of tests available which can be ordered to the patient. And besides starting the empirical treatment, we can order the test. And once the reports are available, we can just we can have a target approach, and we can start the switch to the antibiotic related to that particular agent. Empirical treatment is not beneficial in all the cases. So many a times what we see, the physicians, they start all and maybe anti-malarial, doxycycline, azithromycin. So it is generally not required, because it leads to antimicrobial resistance, and also it is increasing day by day. So we really need to judiciously use the antibiotics. We need to go for the investigations. We need to test all the organisms which are related to acute undifferentiated febrile illness. At the same time, we need to order blood culture, urine culture, so that in 3-4 days we should come to a differential diagnosis, from differential diagnosis to correct diagnosis, and we can start the correct antibiotic instead of giving many antibiotics, which is also leading, we have to think, and we have to think twice before starting empirically any antibiotic. So what I would advise, the treatment before investigation, empirical therapy, and then coming to the target therapy. So that's all from my side. Thank you.
Thank you very much, Dr. Siddiqui. That was, how I put it, very, very informative. And one can see the passion that you have towards empirical treatment, especially because, like you said, it leads to the increase of risk of antimicrobial resistance. But in a country such as India, considering that if you look at from an epidemiological considerations, if you look at the environmental and socioeconomic factors in India, do you think there is something that can influence here the epidemiology of diseases presenting as AUFI? Or, I mean, do you see the landscape of these illnesses changing over the next decade? Is there going to be evolution? Because there is so many fevers happening today that, India, especially being in the tropics, is highly vulnerable to this. Do you see anything changing over the next decade with respect to AUFI and or its treatment?
So right now, like the kind of disease which we are having, and the kind of spectrum, like here, what we are getting more of malaria, dengue. And the second thing is, like many a times we miss the ScrubTyphus cases, the leptospirosis, because many a times what we have seen, that if we have talked to consultant and they have ordered for scrub, and that also has come positive. Even leptospirosis has come positive. So first and foremost, what I would like to say, so like investigation itself is very sparse. So investigation should be increased, so that the right kind of antibiotic or whatever drug, antiparasitic, anti-malarial we are choosing, it should be evidence based, like evidence based medicine, or the evidence based approach. So that we have to work upon. And also, like this is the season, like July, August, September, October. So these are the like 4 to 5 months where we see these kind of illness which are very prominent. But otherwise, the viral infections are also coming in. So many viruses which were not there earlier, and also nowadays we are getting more of viral infection. But then to say that it is viral, it is not bacterial, it is not parasitic. So we need to go for investigation, because what I have seen, the consultant, at the very first time the patient comes, and no patient come with a history of 1 day of fever. Patient will come only after 3 to 4 days of fever, because they will take alcohol, they will take whatever medicine they will want. Azithromycin is like over the counter. Anybody will take azithromycin for the sore throat. And azithromycin has become so common that many people, whatever disease it is, they will take. I will ask, have you taken some medicine? Yes, I have taken azithromycin. So this is the answer. So I think after 3 to 4 days when these people come, so it becomes very difficult for the treating physician also to rule out what exactly the patient is having. But investigational approach, the diagnostic stewardship is the need of the hour. So before antimicrobial stewardship. So that is like my take. Diagnostic stewardship, we should do it. We are not going for cultures. We are giving antibiotic. We are changing antibiotic. We are changing antibiotic in one day. Acha, aaj nahi theek hua. Okay, we'll change the. So these are the things we have to change, and definitely with your support and with your CMEs, it will change. I feel.
I am certainly hopeful of that, ma'am. Very certainly hopeful of that. But given the broad spectrum of potential causes for AUFI, and sometimes I would say they're often overlapping clinical presentations, are there any advances or tools in diagnostics that you believe could help clinicians, swiftly and accurately identify the underlying cause of the fever, or we still wait for day 3, day 4, and the patients doing
Yes,
their
sir. The
own treatment?
diagnostic tools are available now. So many diagnostic tools in the terms of molecular technology, they have come up, and with one sample, so many labs they have like they one sample you give and they will tell you a plethora of organisms whether they are positive or negative. So in big hospitals, definitely they have started doing it, but then again the cost is a factor which not everybody can afford. So
Yes, I
cost is the
mean,
thing.
yeah, given the Indian landscape, do
Yes,
you think anything, we are not, we're still not that country which can carry out molecular testing for each and every symptom presentation. So we
yes.
have to find some sort of a middle ground. I was just, you are an experienced person in this field and as an academician also. How would you feel if there was a, for example, just hypothetically, humor me, if I had a product for, let's say, dengue NS1 as a home test, right? And it can diagnose dengue fever, especially in the first day of after the first day of fever. So if there was something like that available in the market today, and somebody was looking to say, hey, not instead of going for 3 days of treating myself on Dolo 650 or erythromycin, I could do a home test and at least rule out. People did that in COVID. If you remember, people did a lot of ruling out of COVID. So do you think that there is that would aid the diagnostician? It's something radical. It's something new.
Uh,
That's why I'm just
you
raising it
mean
as a
to say
thought out here.
the availability of the test to the public? This is
Yes,
what you mean?
home test, like a home test. Like you have a pregnancy home test, you have a COVID home
Yeah.
test.
Sir, the only thing is like the home test means if you are talking about dengue, then again the drawing of blood, and also like you have to take the serum and all, like how like
It
what
would be a
are the
whole.
technologies?
It would be a whole blood
Acha,
test.
whole blood. So then
A whole
again there
blood.
can be false positive. Yeah. Okay,
I'm
whole blood into the
whole blood, single drop of blood
sir.
onto a test.
Yeah.
Simple
Okay.
procedure. But I'm running the thought because it's something radical and something that's not been done. But it could aid, our our medical system in the long run. Yes, I know people. In any case, they go to Google and they do their own research on what is wrong with us, right? And you have
Yeah,
a
and they
fever
will
today,
they
and
will go to lab and they will do the get the test done by themselves before the doctors that is there. But in home test, if they are doing, I don't know how like the false positive or false negative, that also could be an issue. Then second is like if they have some kind of disease and if something comes positive, then like it will not come to the knowledge of the consultant. So after that, whether they'll go for the or they'll start medication themselves only. So this is
yes,
something I we
lot
need
of
to
ifs and
find out.
buts.
Maybe a pilot study. Maybe maybe what we can do, we can make a questionnaire or the Google form, and we can just circulate, and we can just know the thought process, and we can just find out what exactly people think of having a home-based test, and how are they going to take it further.
Absolutely,
So once we
absolutely.
get the idea of their one, we should read the minds, because what I know, over the counter usage of antibiotics has led to AMR. So over the counter using these diagnostic tests still is, I don't know, it's unpredictable, and we need to find out. So this can be
I
a
would,
research
that
area.
was always the question. I asked this question to myself several times because I was wondering, the first person who introduced the home test for pregnancy, what was he thinking, or what was she thinking? That would also have been one radical thought process at that point of time, right? But yes, your point is very valid, and you know, uh,
No,
like
but
I
it's
said,
good. It's good hypothetical question, but this can be, when we do a research, the first is to frame a hypothetical question. So the first
no,
part you have done, maybe you can
I was
formulate a.
actually not talking in hypothetical, ma'am. I had that home test here right now in my hand. That's
Okay,
why
okay,
I actually had a home test here. So that's why
okay,
I was actually just running the question by you. Like, what can happen, what
okay,
could be done. Uh, just to
okay,
have,
sir. So,
just
yeah,
to give you an interesting thought out here, Govind, since you are in Lucknow, I'm going to send you some home tests in Lucknow. And, I'm sure ma'am is doing dengue testing at her laboratory as well. She could, since ma'am has been so kind to recommend a pilot study, I will ask ma'am to support us on this now, right?
no, definitely, because whatever question comes to mind, that always has some basis, and whoever tries to get the answer only gets success. So if you have a question in mind, you work on it, and you have people around you to help you, so definitely you will get the answer. And that answer, whatever answer is, we are ready to face it. It can be either yes, or it can be either no. So
Absolutely.
it's not that whatever research question comes to your mind is always good. So the coming question and then finding the answer is, it's good. So maybe in future somebody else come, and then you have at least the answer. No, you have done this pilot study, and yes, it was beneficial. No, it was not beneficial. These are the
I'm,
two answers. No third
I,
answer.
I always
So
think it's always beneficial. It may not serve its purpose at this point of time. There's a right place and a right time for everything. And
yeah,
every
maybe
technology
in
today,
future, yeah, yes, that can
you're on mute, ma'am.
have means they are smart enough that they will do at home, and they later they will go to doctor, and doctor is also happy. Okay, he has done at least one test, and he has diagnosed himself. So like, if everything is positive, then it's good for patient only, because he'll be diagnosed at the right time, and also the treatment also, because for dengue there is no antibiotics to be given. It's only the
Absolutely.
bed rest, and also the paracetamol, and also the fluid therapy. So going for dengue will not do any harm, because many a times many tests will need initiation of antibiotics. So again, antibiotics, I think that has to be taken care by the clinicians.
Absolutely. That
So
that I'm very clear. Any
I mean, it's
treatment is
my
always for the
perspective.
doctors.
Yeah.
Any treatment is always for the doctors. We are just here to help our medical practitioners and getting them a better diagnostic result.
Yeah, yeah. Dengue is there, and okay, the patient will take rest. Maybe with rest within 7, 8 days, I've seen dengue cases getting recovered. So that can be helpful. So you can start with a pilot study, and let's
We'll do
see.
that, ma'am. We'll start with that. But
Okay.
thank you so much for your time. Right. Ladies and gentlemen, first and foremost, I'd like to express my deepest gratitude to each of you for joining us today for this enlightening session on acute undifferentiated febrile illness. It's a topic of profound significance, especially in the context of public health. And thank you for your interest and engagement. I'd also like to extend a heartfelt thank you to our esteemed speaker, Dr. Siddiqui. Your expertise, ma'am, passion, and dedication to the subject are wonderful. Your presentation not only shed light on the intricacies and challenges of AUSI, but also empowered each of us with knowledge. Thank you very much. And we'd just like to present a little digital certificate to you. We still live in the era of
Thank
Zoom. Govind and his team members will deliver the final certificate to you in person soon. But thank you so much for your time, ma'am, and lovely
Thank
meeting
you.
you again. Have a good day.
Thank you.
Thank you all, everyone. See you all in a couple of weeks where we'll be doing our next webinar on the subject of dengue. Thank you.